Okay, so you can start again. So proceed, Ian.
Thank you. And so the different types of refurbishment options that we see here in this table, purposive refurbishments, were focused on particular interventions, and low carbon refurbishment, which are a much more both comprehensive in their means, but they are really focused on being able to reduce carbon emissions, so the use of either renewable energies as a part of that system. And so really, these are the sorts of impacts in terms of the vectors between energy efficiency and exposure change and health outcomes. And how is it that we've been able to identify, what evidence exists that tells us about those impacts? Because I think this is where, for those working in the field, for those who are policymakers who want to understand the issue better, one of the key questions is what evidence exists and how is it being derived, and can we trust that it's comprehensive in its findings? So to say, yes, there is quite a lot of evidence, and there is a systematic review that was carried out by Maidmont looking at 36 studies. These were very selective, which is the impact of energy efficiency in households on health and well-being. So the review system that they undertook was really around being able to identify all the studies that might have a positive or negative effect. So the tree diagram on your right illustrates, if you go to the positive side of the scale, benefits. If you go to the negative side of the scale, harms. And what you can do with these types of systems is say, well, overall, the pooled effect of retrofits on health. Now, of course, all of these studies are very different. They will have a different type of intervention, etc. But just to say that there is evidence on this, and there are ways in which one can kind of discern overall effects. The findings of the study were that household energy efficiency interventions led to a small but significant improvement in health. And I think that, as you look at these studies, knowing more about each one is quite important. So a further review by Willand et al. Looked at 28 different programs, and they had a broader scope. They want to look at the warmth in the home, affordability of fuel and psychosocial factors, and air quality. And their findings identified that interventions did improve winter warmth and lowered relative humidity. And again, looking at the vector for that is temperature rise and reduces the amount of humidity in the air, increases the availability of it to hold moisture. And the benefit of cardiovascular and respiratory health. Again, these will be two interrelated aspects. The other thing they found is that energy efficiency improvements did result in more kind of well-being and usage of the home, and again, around autonomy and social status. So they have 4 different routes by which one might look at this health outcome. So draft proofing, which would have effect on air leakage and air quality, can result in higher relative humidity and risk of mold, depending on which way and how that's being done, which results in a greater increase in biological and chemical exposure, and that has an effect on respiratory symptoms. So basically, also affecting physiological health, so those who have respiratory diseases. Energy efficiency, which focuses on insulation, again, can reduce heat transfer and increase warmth. That can result in lowering the relative humidity via temperature, and therefore reducing biological and chemical pollution from molds, and reducing the cardiovascular symptoms, improving health. In terms of affordability, for example, in the UK, we've had for a number of years a winter fuel payment, which is provided to older households during the Christmas period, and they are provided with an income supplement of approximately £160 or £140. And that's provided, and if you look at how, for example, increasing energy efficiency from the heating system, which reduces your bills, either could allow you to spend more on heating, which could reduce stress and anxiety in terms of being able to afford that heat. And the further route they looked at was psychosocial pathways, and for example, the use of renewable energy, which could relate to greater satisfaction with the home and improve social functioning and social health. I'd say that the routes on the right become harder to measure in terms of the outcomes that we were looking at earlier. So further study looking at Europe, just more broadly, was looking around how reported health outcomes in the European Quality of Life Survey among the 32 European countries. And really what they find is there's an uneven concentration of, say, energy poverty and poor health outcomes. And the figure on the bottom, the darker line at the bottom, illustrates the non-energy poor population who have a poor health reported. And those who are in the energy poor tend to have a much higher poor health. So again, there are many interrelated factors that would be drawing on that. For example, the poverty in general tends to be worsening for health, and these will be not separate. So where we pull a lot of the evidence that we have in the UK around the outcomes, so winter excess mortality is high among Europe, and this may be because of the quality of the housing stock. So this study carried out by Wilkinson on social determinants, the environmental excess winter deaths, pulled together data from the English Housing Survey as well as cardiovascular disease deaths at the postcode level, and pooled these together to be able to look at the effect that indoor environment might have on health outcomes. What they found was that the warmest 25% of homes and the coldest 25% of homes would have a different, I apologize, the figure is slightly small, a risk of death relative to the summer minimum. Basically, colder homes had a higher risk of death during the winter period. And this figure on the bottom illustrates when the outdoor temperature decreases, that risk increases. And so that's what that is illustrating, is that many more people die during the wintertime due to cold-related death than they would do during the summer. So a more recent study, which was looking at a community-based retrofit program, found that generally energy efficiency measures contributed to well-being, and in particular helped in the social feeling less isolated, being able to make better use of the home. But in the metrics they looked at, they didn't find an improved mental or physical health in terms of accessing to the National Health Services. And there's a lot of ways in which these types of programs being delivered and being sought and being evaluated can really paint a picture around what the impacts might be. This suggestion of their work was that area-based programs may not improve chronic health conditions. Now, they were looking at a defined period of time, so it's unclear always about how the long-term exposure to that change in the environment might actually play out. But what this illustrates is the bottom, top right, is that among all groups, there was a limited effect around cardiorespiratory disease, chronic obstructive pulmonary, cardiovascular, and respiratory in terms of hospital admissions. So there's people entering the hospital for these diseases and being coded that way. But when you look at those who were above the age of 60, there was certainly a positive effect. And so this is, again, where certainly in terms of emergency admission category, those entering the hospital system among older patients was reducing. They also did a follow-on study, or part of the study, which is looking at secondary impacts. And what they were able to find was that the interventions of retrofit did have an improvement on financial and thermal satisfaction. So again, you're kind of seeing a theme crop up that there is a lot around here. And indoor environmental temperatures did tend to increase as you were to introduce these retrofits. Now, an increased indoor average temperature of 1.5 degrees doesn't sound like a lot, but in fact, it can be quite an increase, because during moments of using the home, those temperatures will be higher. And so this illustrates, for example, on the right, the time of day that you had these increases during the night and the evening when people would be in the home making use of their space. So this is quite an important effect. Further analysis was looking at social housing, and again, here it was a complicated outcome. The retrofit cost and the effect that had on access to health services there was an effect. but it wasn't really certain about how long that effect might last and the cost effectiveness of it as compared to the cost of the intervention. But again, that there were real outcomes in terms of the satisfaction and the use of the home. So looking at the air quality side, some work recently in Ireland, looking at concentration of indoor air pollutions among three-bed semi-detached homes. And so they were monitoring before and after energy upgrades. And this is one of the key risk areas that we think are going to affect our health in the longer outcome, and hence the reason I focused on air quality at the beginning. By increasing the air tightness of these buildings without proper ventilation, and remember, many of our homes in the UK are being ventilated primarily through users deciding to turn fans on or open windows, or to make use of small vents in the windows. And the problem becomes one of experience. So people just tend not to do that, or if they do tend to open the windows in the wintertime, they get a cold draft. So it's typically not done. So really what this does show, however, is that the air tightness decreased, and they were also able to identify a number of pollutants that increased in exposure. And I think that's where the real risk lies. So again, I won't go over this one, but again, there was an effect on mental health. And a recent study also looking at the health survey for England, and when people are getting these surveys, they have a blood pressure measure, which requires a temperature check as well. And so this is, again, a kind of an issue whereby for every increase in the indoor temperature, there was an increase in the risk of poor health. And this is a visit by a nurse. It is a one-time temperature snapshot, and it's also a assessment of the reported health outcomes based on that nurse visit. Now, what could be going on? Well, it's unclear, and we haven't been able to identify what the drivers are per se. But the reality might be that these are people who are living in homes that may be easier to heat or warmer, and older people living in certain types of homes, older people tend to have worse health outcomes. So these kind of complicated pictures really make clear how difficult it is to be able to connect between all of these different impact points. And so this gives you an illustration, for example, where on the low indoor temperature from the study hypothesizes among privately rented or high education, you might be able to effectively mitigate against that by making choices around your activities or being out of the home, for example. A high indoor temperature could be related to a larger household or higher income. It could be also related to socially rented homes, and therefore it confounds some of the effect that might have in terms of health. So some study by some colleagues were really looking at the unintended consequences and the complexity of the relationships between improving building performance and health and environmental outcomes. And really the point here is to make the case that it's not always a clear win, nor is it always a clear loss, and it is complicated. And so when you look across the ways in which you might have an effect, both positive and negative exist across most all of these. And so that's very important to take note of. And in terms of being able to, for example, illustrate those connections, and this is a diagram which our colleagues designed as part of a housing, energy, and well-being study using system dynamics. But the point here is mapping all of these connections out and being able to measure and monitor these for, say, health impact assessments is really complicated. And therefore, you rely on larger, more hidden proxy indicators. So how is it that we're going to be strengthening the evidence? Certainly in the UK, as you've seen, we have quite a lot that has been done, but it's also a complicated picture. And as we say, that we anticipate that there should be benefits in some realms if it's done in a way that can be used to protect health. While at the same time, if it's not done through thoughtful thinking, or users of the home don't understand how to use a system or understand why it's important to be able to, for example, ventilate, then you could have health harms. And that undermines the programs that might be designed on that basis. So energy efficiency in buildings we know has an effect on thermal and air quality, and there's a potential trade-off. This figure on the right is just illustrating that for radon exposure in UK homes, and really to say that while radon action areas, which are parts of the countries that have a high exposure to radon, are identified and mitigated against, there are many in the lowest radon areas where that exposure is going to be the greatest amongst most people. And radon is the second leading cause of lung cancer outside of smoking in the UK. So the challenge that we have in the UK is being able to clarify the ventilation guidance around retrofits. And this is partly to do with the way that the guidance doesn't require any follow-up monitoring to be undertaken. So it's really reliant on the assessor for the retrofit program to be able to go into a home and evaluate what needs to be done. And it's very reliant on the builder who comes in and installs these systems. And then it's crucial that they are able to transmit information to the occupant to be able to make use of that in a way that is beneficial. So there's really no requirement to be able to map that through. And the problem that you get is the situation you see on the right, where these are a trickle ventilated double glazed window installed into what my guess would be a council housing block. And the reality here is that those trickle vents are probably closed the vast majority of the time. The mold buildup that you see, which is occurring along a cold bridge, so this is where the outdoor bridge of the window is meeting the indoor surfaces, and warm moisture built up in the air from cooking or showering, etc., just doesn't have enough colder air that has lower levels of humidity to be brought into the home and therefore mitigate this. There's a single arrow. So another example is how retrofits, we're looking at how they might affect radon exposure in homes. So before the figure was illustrating simply the exposure levels, but what this diagram is showing, some recent work that we've just undertaken at UCL, is looking at how retrofits might change this exposure distribution. So this is all radon measurements in a sample of UK housing, and the red line is the radon action level. And it's a bit hard to see from this diagram, but when we look at different housing types, we see a shift in terms of how their performance or retrofits might associate with a higher, in other words, a more concentrated distribution of radon. What that might imply is that this figure here is that by installing wall insulation or loft insulation or glazing or draft proofing, that we may actually be increasing the risk on radon. And that's partly to do with, as I said before, the air quality and the ventilation side of things. So these are really important factors to be able to understand how we could be affecting health, and therefore our evidence base in the UK needs to be better strengthened to understand what are the things that are driving that increase in exposure. So a figure which illustrates this, again, these diagrams are helpful, but this was used in developing the UK's health impact assessment model for housing. And this is a health impact assessment model that's used in government impact assessments. So this is part of the model that we helped build. And really we can look at the housing stock and the people who live within, looking at policies that can be determining what type of efficiency measures are actually undertaken, which changes the building characteristic. And then really looking at how the contribution to indoor environments in terms of the pollution sources that we had evaluated, being able to look at how people make choices around their occupant behavior, whether they're in the home, whether they go to work, whether they have the ability to maintain the warmth, and looking at the interconnections those has across the exposure field. And then knowing from historic epidemiological evidence, what sort of change in risk that might result in. And therefore, if by introducing energy efficiency measures that do change these exposures and therefore has an effect on health outcome, we can calculate the mortality and morbidity impacts. One of the things that in this model that we are really keen to make sure that is understood is that it doesn't result in health benefits just because. It really maps out and means that if, for example, a retrofit program goes forward and doesn't include air quality as a part of its program, then that's something that will have potentially a large negative effect. despite the fact that you might be improving temperatures and reducing mold growth. So a quick example of a study that we undertook to illustrate that was these different scenarios of being able to undertake a comprehensive retrofit program of the like that is being described by UK government policy. And really just illustrating that if you were to install without any regard for ventilation, then you have these negative effects. And that's the scenario one. Scenario two was in the assumption that installers who enter the home who have a visual cue about the air quality, such as mold growth, or kind of in the survey that we use to govern the model, whether there's a tendency to smell molds or kind of what's defined as mustiness. And then the third example, which is if one were to actually introduce as a part of all the retrofit program ventilation requirements, then this would help to mitigate that and result in a lot more benefit than we would anticipate. We can translate these types of results into the effects on health services, and we do that by saying if we were to have an exposure change and we were to change the risk of the disease itself has a number of people who enter the hospital system, and we would affect that entering into the hospital system, and therefore each time someone comes for that disease, we're reducing it and the cost for that. And this is a benefit of having an integrated health system in the UK that allows us to be able to calculate and evaluate these costs. The final piece that we're working on in the last few moments is many countries, or at least certainly in the UK and other European countries, have a pool of data that has been collected for a variety of purposes. So in the UK, what we have is surveys, such as I mentioned, for health. And so we have an annual survey that is run each year to collect information from between 14 to 20,000 people per year, depending on the focus area. And we have longitudinal surveys of aging, for example. So this is a cohort study, collecting information from the same people year after year and evaluating how their circumstances have changed. And again, with a view about their health and well-being. So these two surveys can be coupled with something which was built up over time by the UK government called the Home Energy Efficiency Database, and is now called the National Energy Efficiency Data Framework. And this includes information on every single home in the UK in terms of its energy use for gas and electricity, as well as any retrofit programs that were installed via government programs or supplier obligation programs. And what that means is that we've been working with them to be able to develop a connected data source. And this is really being able to look at, by taking the health survey for England and its survey on health outcomes and the information about the home, the fuel use, whether they are part of any types of programs, and looking at their health. And that's also true for the longitudinal survey. And a cohort study is very powerful when looking at health outcomes, because you're, for the most part, able to identify things that have remained the same and things that differ amongst those households. And you're able to control for that and effectively say, we think we can attribute a change to this possible intervention. And so for the longitudinal survey of aging, the real premise here is that we can do before and after effects of retrofit programs that have been installed among these households. And ultimately, this is able to link into a series of objectives we have about being able to improve that evidence base. So looking at how interventions affect energy use and fuel expenditure, which I think we generally have quite a good view on, although there's not always certainty about what's affecting where there may be a gap between anticipated performance and actual performance. Being able to look at the interventions in terms of indoor temperature. There is a guidance that has been provided by both the World Health Organization as well as the Public Health England that have identified between 18 to 21 degrees as being of a temperature which doesn't which doesn't affect health, and nor does it cause ill health. And the issue there is that we know from other studies that the vast majority of, say, older homes do not maintain a temperature of between 18 to 21 degrees. And in fact, it's very often lower than that. And so being able to better understand what type of guidance should be provided in that circumstance. And really we're able to then look at thermal environment impact on health, such as temperature, and then intervention impact on health. Whether there are other things that are latent, that are unseen within the data that we can postulate on, or what might be affecting health outcomes. So in the last few moments, a few thoughts on the evidence as it exists in the UK and some of the drivers. We know that the built environment has a significant impact on health, but it is both positive and negative, and that's really important to understand. That appropriate interventions can improve health, and they can coincide with response to climate change and energy security. And really, our point here is that by improving building performance, building fabric, thermal environment, in a way that mitigates against air quality, we can have health benefits. It's complex interconnected set of factors, and really being able to think through the unintended consequences of a program, which could otherwise undermine the premise of these interventions to improve health. And really acknowledging just how complex this is doesn't mean that it can't be addressed, that these things can be studied and they can be modeled and they can be known. So some key messages in the UK, and I think elsewhere in Western Europe and in countries who are tackling energy efficiency in housing and buildings, these are going to be some of the largest natural experiments to be undertaken, certainly in the UK. And we do need to understand what the health impacts are. And the natural experiment is really one where it's a real-world intervention, and it's happening without the protocols or the standards that a normal, say, intervention program might have. There's a lot of different pathways around energy efficiency that affect health, cardiorespiratory, cardiovascular, mental health. And mental health really shouldn't be undermined in terms of the long-term, the short and long-term effect. As you saw, the evidence is very strong for it, in as much as the immediate responses from people experiencing retrofits and improvements in their home. Methods for determining health impacts really requires a lot of careful planning and execution. As you saw, the studies that we looked at had a variety of outcomes. The longer you can study the problem, the better you're going to be able to adjust and understand the drivers that are affecting the outcomes. And finally, retrofit programs do deliver qualitative benefits as well. And although the extent of the impact is not always straightforward to attribute, it is a strong and important factor. So as I say, with careful planning, energy efficiency retrofits can result in health improvements over the longer term. And on that, we have a set of questions which, Hans, I'm not sure if we show them all now or if I'll just go through them. But some that I thought would be interesting for you to think about was, does the argument of health benefit of energy efficiency really work? Another was, what evidence do policymakers need to make the case for programs and regulations that protect health through energy efficiency retrofits? What actions do those working on housing retrofits need to prioritize to achieve beneficial health outcomes? And what key messages need to be taken forward to ensure that health benefits are achieved when implementing those retrofit programs? Oh, and that's it. So I'll pause on here.